we are going to go ahead and get started for this February edition of Pain Research Working Group. Welcome, everyone. Nice to see you all. Today we have Drs. Monica Patel and Elisa Johnson. I'll be talking about applying the NIA Health Disparities Research Framework to chronic musculoskeletal pain. A presentation I'm sure we're all looking forward to. I want to take just a couple minutes to make a couple of announcements from PMOP that they've asked me to share with all of you before we get started. They wanted to say that, so there is, for those of you who don't know, there is an NCCIH Pain Management Collaboratory new funding opportunity. And we had a cyber seminar about that a couple weeks ago, and PMOP and some other partners were able to attend. And they wanted to thank everyone who has reached out to them with questions about applications. They've gotten back to many of you. A couple of you, they know they still need to get back to, but they're aware of it, and your response will be forthcoming. They just wanted to have that out there. If anyone is interested in the best way to get questions to PMOP about that particular application, they do have a special dedicated email address, which I'm happy to send to you if you send me a note in the chat if you don't have it already. And they also wanted me to mention, so PMOP has 3 RFAs that are out now, and these are not research RFAs. These are to fund actual clinical positions for 3 new programs that they have to support the expansion of interdisciplinary pain care services. So each of these is funded, and the funding can be used to hire clinicians. And there is funding through 2026 for those who are selected. And they want to encourage people to apply. The due date is February 28th. So just so folks are so they know, if you aren't aware of this, so there are 3 kind of programs that they're looking to fund clinicians for. So these are active management of pain. And this is about providing an approach which leverages the knowledge and skills of clinical psychologists who have health-focused treatment experience or interest in chronic pain, alongside physical therapists who have experience or interest in chronic pain management and pain neuroscience education. So that's one. That could be hiring a psychologist or a physical therapist. There's a medication management and pain management treatment teams initiative to expand access to safe and effective pharmacological management for pain. And this is for the hiring of clinical pharmacist practitioner, nurse practitioner, or physician assistant. And then there's a whole health coaches and pain management teams initiative. This is to provide care to veterans who are looking to engage in the whole health method. And this would support the hiring of whole health coaches. So there are RFAs for these. If you haven't seen them and you'd like me to send them to you, send me a message in the chat and I'll do that. So without any further ado, I want to thank our speakers for joining us today and go ahead and introduce them. Today we have Dr. Elisa Johnson, the behavioral scientist and licensed massage therapist, conducting clinical translational research to improve understanding of biopsychosocial factors driving inter-individual differences in chronic musculoskeletal pain and pain-related disability in older adults, including health disparities. The overall goal of developing tailored, mechanism-based, non-pharmacological interventions for improved. And she is in the Department of Community and Behavioral Science. And also we have Dr. Monica, fellowship trained in pain medicine from the University of Texas MD Anderson Cancer Center in Houston, specializing in interventional pain management. While also interested in all aspects of pain medicine, training has also included emphasis in treating spinal and cancer-related pain. She's assistant professor, Department of Anesthesiology, Division of Pain Management, University of Florida. So with that, I'll turn it over to our presenters. Thank you, and I would encourage anyone who has questions to please put them in the chat, and we will get them in the Q&A period at the end. Thank you.
Thank you so much for that lovely introduction. My name is Dr. Monica Patel, and applying the NIA Health Disparities Research Framework to chronic musculoskeletal pain was sort of our labor of love. So this is our behind-the-scenes look at how we developed this paper. We like to think of our patients sort of as the dice depicted in this picture. They're multifaceted, and they all have different shapes and sides and descriptions, and they're all dynamically sort of rolling and interacting with each other. And they're not equitable. The context for the study development really stemmed from this long history of health inequities that has been ongoing for decades. And over the years, there have been different frameworks and concepts and ideas proposed. And in 2019, we came together and developed the concept for this paper. It was built on the National Institute of Aging framework that was put forth by Carl Hill, and it was presented at the American Pain Society conference in 2019. And so a group of us came together and thought this would be a great way to systemically approach health disparities and chronic musculoskeletal pain, and also bring awareness to what's in the literature, what needs to be further developed. And the goal was to inspire this collaborative effort for policy change, identifying areas of targeted approach, and also an interrelationship or collaboration between clinicians and researchers. Historically, research controls for race and ethnic differences. Ethnic groups are not equally represented, and that can be because they may not be recruited in equal numbers. They may also have their sort of their perspective or data sort of in a minority within the larger group. And also, oftentimes, if there is a racial or ethnic difference, it's controlled for in the end results. So really characterizing that racial ethnic difference is not fully understood. This is the NIA framework that we have published in our paper that is sort of borrowed from Dr. Hill's paper in 2015. And basically, the framework outlines throughout the course of a lifetime different levels of analysis that include environmental, social, cultural, behavioral, and biological. And within each of those levels, there's different factors, healthcare factors that are denoted, which we used as a guide doing a very focused literature review. Since then, the National Institute of Minority Health and Health Disparities Research Framework was published. And it's a very similar framework in that it has multiple levels of analysis throughout the course of a lifetime, but adds a different or an additional dimension, which includes the level of influence from individual, interpersonal, community, and societal, and how that affects health outcomes from the individual health, family, organizational health, community health, and population health level. So we just incorporated this, as this has been sort of a new a new way of looking at health disparities that when we were conceptualizing the paper, we were not using. The methods of our literature search include inclusion criteria of chronic musculoskeletal pain, ethnic race differences. They had to include a framework term. It was only articles conducted on individuals 18 or older, and only studies conducted in the US. The search strategies used PubMed and Web of Science databases, and the articles had to be published between 2000 and 2019. 52 articles met the inclusion criteria, although many other articles were reviewed. In the paper, you'll find a very detailed summary table for each of these articles. And so for purposes of this presentation, and to sort of foster collaborative ideas or spark some interesting conversations, we decided to also include more of our perspectives when we were doing our search. The first level is the environmental, and that included geographical and political level of analysis. The health factor terms included structural bias, immigration and documentation, criminalization, residential segregation, urban or rural residents, and toxin exposure. Within our narrow search, we did not find any articles that met this criteria. But during a more broader concepts were evaluated or sort of became aware. And by broader concepts, I mean concepts where chronic pain was studied and not specific to chronic musculoskeletal pain, or chronic pain without race or ethnic differences. Those types of studies did show that there are fewer adequately stocked pharmacies. And I actually find this in my own clinical practice, where I will write a prescription, and especially patients living in more urban areas or rural areas, the pharmacies are less likely to carry opioids in high supply because they're worried they'll get robbed or other stocking shortages, and they'll have to sort of shop around and go to different pharmacies. There's less access to non-pharmacologic pain interventions. Prescription opioid abuse and poisoning was more common in rural areas. And state and local policies differ by citizen status, ethnic race differences, and other social hierarchies. The next level under environmental is socioeconomic, and the health factor terms included are education, income and or wealth, occupation, English language proficiency, and this resulted in 2 articles. The conditions were fibromyalgia and knee pain or knee osteoarthritis pain. And in these articles, what was found was African American patients, particularly from lower socioeconomic income levels, had higher pain severity compared to their other racial counterparts. Now, broader concepts, again, if we expanded our search terms, there seems to be a theme of lower education and lower income having a higher pain prevalence. And occupations such as manual labor jobs, blue collar, posed higher risk factors. And some of those occupational risk factors were found in articles that were not included in the US. They were more international studies. And grandparent caregivers, particularly those caring for younger grandchildren. And educational material regarding self-care, appointment information in preferred language led to higher compliance. And that study did not have a racial ethnic difference, but they did provide material in Spanish, which was the language of preference. The next level is healthcare. Health factor terms include healthcare access, insurance, quality, literacy, and numeracy. There were 16 articles included in this, primarily osteoarthritis of the knee or low back pain. So again, neck pain or other arthritic joints seem to be underrepresented. Concepts included pharmacologic opioid prescribing practices, which had varying results regarding racial ethnic differences, performing diagnostic tests, surgical or interventional treatments, referral to specialists, and healthcare cost and utilization. Now, when those same healthcare terms were sort of expanded, there seemed to be some themes of lower health literacy related to lower pain medication knowledge. And there were no studies on numeracy, which for me particularly I thought was interesting, because numeracy, especially in the context of patients taking opioids and being non-compliant or accidentally overdosing, if their numeracy of the number of pills they're supposed to be taking in a day or understanding of the milligram dosing is not there, then that's a real area for targeted interventions. And quality of care in general seems to be defined or determined exclusively by pain severity, functional level, and financial burden, which maybe there's room to expand what the quality of care actually is defined as. Social cultural is cultural, social, and psychological. This is sort of a summary table. The health factor terms included values, prejudice and norms, traditions and religion, collective responses, stress, family, financial, occupation, and residential, institutional racism, self-concepts, stigma and bias, loneliness, and stereotypes. We found 6 articles. The conditions were osteoarthritis, knee and hip, and low back pain. Again, limited conditions studied. And the concepts, patient medical decision making. And this was interesting. The articles showed that the medical decision making could be influenced by their understanding or exposure of the treatment, if they had friends or family who had undergone a similar treatment, and also their education level also influenced it. There was also some the patient's surgical perceptions, caregiving for family members, life and financial stress, discrimination, religious coping, and seeking social support, which did show a racial ethnic difference between African Americans and non-Hispanic whites, as well as Hispanics. And anecdotally, at least in my clinic, I do find that patients' sort of biases and medical decision making do come from their experiences regarding other family members or friends who've undergone that similar procedure or surgical treatment, and may also be limited by stress regarding if they're going to have transportation to that appointment, or if they're going to have a financial burden, for example, having back surgery and being out of work for 6 weeks, and things like that. So there was definitely some correlations or connections that I could make with my own clinical practice. And now I'm going to let Dr. Johnson take over.
Thank you, Anika. Okay, so just to kind of reorient ourselves, these are the broad levels of analysis within the NIH Health Disparities Research Framework. And so Dr. Patel has talked about the environmental and the sociocultural levels of analysis, and I'm going to briefly go over what we found for the behavioral and the biological. So under behavioral, there were coping factors, psychosocial risk and resilience, as well as health behaviors. Next slide. So for behavioral coping factors, our health factor terms included active coping, problem solving, stress management, cognitive reframing, and emotional regulation. Again, we restricted our search terms to those included in the NIA Health Disparities Research Framework for this particular search. And we identified 8 articles with the conditions of osteoarthritis, knee pain, rheumatoid arthritis, migraines, and systemic lupus. And the concepts that we identified was that there was a greater use of passive coping strategies among certain ethnic race groups, but that some of these what we think of passive coping strategies may not operate equally across groups. So for example, in one study, they reported that problem-focused and emotion-focused coping was positively correlated with pain severity in whites, but it was negatively correlated with pain severity in non-whites. And that's how they classified their groups, so whites, non-whites. So you start to get this idea that maybe some of our ideas about passive coping and what that means for pain doesn't function equally across groups. But again, this was a little bit limited, so it's hard to draw those hard kind of conclusions. We also saw the effects of perceived stress, emotion regulation, and overall coping was moderated by ethnicity and race. And our broader concepts were a little bit limited here, which was actually very surprising. But I guess specific to chronic musculoskeletal pain, it was limited. The next factor under the behavioral level of analysis is psychosocial risk and resilience. And here we looked at the terms for social support, discrimination, pessimism, optimism, and control. We identified 8 articles with the conditions of osteoarthritis and chronic musculoskeletal pain. This was various types of chronic musculoskeletal pain, so there wasn't a lot of research done in this area, honestly, which was, again, very surprising. The overall conclusions that we could draw here is that social support and discrimination are key factors in the experience of chronic pain. So there were a couple of studies that reported non-Hispanic Blacks sought out more social support compared to non-Hispanic white peers, and that in one study, that quality of social support was actually rated lower by participants, non-Hispanic Black participants, compared to non-Hispanic white participants. Other studies reported no difference between the 2 groups. So it's not really clear how social support is functioning across different ethnic race groups, but it appears to be an important concept for sure. And then discrimination consistently was related with worse pain outcomes. It is a strong predictor of pain, depression, and pain sensitivity, including clinical and experimental pain sensitivity. And then the final part of this, we looked at some of these psychological risk and resilience components. So traditionally in research, we've looked at a lot of the psychological risk factors, but we've looked less at these resilience components like optimism, perceived control. One study we did identify looked at optimism in non-Hispanic Black and non-Hispanic white individuals with chronic knee pain. And what they reported is that optimism actually was associated with lower movement-evoked pain in the non-Hispanic Black population, but there was no relationship in non-Hispanic whites. So again, this starts to kind of give us that idea that maybe some of these factors that we thought were traditionally the same across everyone, they actually don't, and they may provide greater protection and be more buffering in certain ethnic race groups. So it's an important thing to look at going forward. And then we also were able to identify one study that talked about perceived control, again, comparing non-Hispanic Blacks and non-Hispanic whites. And they reported that perceived control over pain was lower in the non-Hispanic Black participants versus the non-Hispanic white participants, which may exacerbate the pain experience as well. And then the final factor under this level of analysis was health behaviors. So for this, it was smoking, anger and violence, alcohol and/or drug use, nutrition, and physical activity. And here we were able to identify 18 articles that looked at arthritis, non-cancer pain, back pain, and other various musculoskeletal pain conditions. So for smoking, we found that smoking rates are higher in underrepresented populations based on this literature, and that may increase the risk for severe chronic pain. For anger and violence, there were no studies. This was really surprising to me as well, especially considering the identified relationships between discrimination and chronic pain severity. The anger and violence, have not been looked at specific to these search terms yet. The findings for alcohol and drug use, again, were very, very limited. We found one study that discussed greater alcohol use in African Americans and Native Americans, that it was associated with actually less pain reporting. And then we identified one study that talked about cocaine use among non-Hispanic whites and non-Hispanic blacks, and that in non-Hispanic blacks, cocaine use was associated with more low back pain, but this relationship is not found in non-Hispanic whites. Again, these associations are being identified, but there's really no indication about directionality or how these factors are interrelated. For nutrition, we identified several studies that looked at vitamin D deficiency, and vitamin D deficiency was consistently related to worse chronic musculoskeletal pain, with African Americans showing deficient vitamin D in multiple studies. And then broad concepts for physical activity. So physical activity is associated with lower pain reporting, and that's pretty consistent throughout all the literature. For our specific search, there were several studies that looked at physical activity education interventions, and they were consistently beneficial across multiple ethnic race groups. So this would be a really good target area going forward. However, in our broader search, we did start to recognize that there are some very significant disparities in achieved physical activity. So whether people are achieving that recommended level of physical activity, which is probably driven largely in part to environmental and sociocultural barriers within different groups of folks. And then the last level of analysis within the NIH Health Disparities Framework is the biological. So here we looked at physiological indicators first, and this included comorbidities, cardiovascular functioning, sympathetic nervous system, the hypothalamic pituitary adrenal axis, and inflammation. We were not able to identify any articles specific to our narrow search terms. What we did find, though, is that comorbidities in general are associated with greater pain, and that chronic pain is associated with increased mortality risk. We also found that nervous system dysregulation is present in chronic pain, particularly thinking about blunted sympathetic nervous system activation, so responses to stress may be blunted, and that may be associated with greater pain. And then also inflammation is associated with greater pain. But again, there were no studies specific to our criteria looking at these factors. And then the last set of terms, this thing kind of comprises genetic stability and cellular function. And so these health factor terms listed every here on the side, nutrition, epigenetic alteration, and so on. We used all of these search terms, but we also broadened this just a little bit to try to be more inclusive, and we still did not find any articles related to ethnic race group differences in chronic musculoskeletal pain or pain disparities. But we did find some articles that began to talk about the biological interface of genetic stability and pain, and that chronic pain appears to be interrelated to changes in the epigenome. So there is some areas ripe here for investigation, particularly looking at how environmental factors and genetics interface to place individuals at a greater risk for chronic pain and poor health outcomes. And emerging evidence suggests that chronic pain is actually related to changes in the epigenome. So some of the work that I'm doing currently right now in my lab, we're looking at epigenetic aging and chronic musculoskeletal pain to better understand how these two things are interacting. And there's been some work done on telomere length and worse pain outcomes as well. So this is an area rich for research specific to health disparities moving forward for sure. Okay. So just to briefly outline the limitations in the current literature that we've found, and this is, again, not to kind of be a downer on what we have, but just to better understand where we need to move. And first, for a caveat, I will say many of the studies that we found came from the VA. So I will just encourage everyone from the VA that's listening right now, you guys are doing a great job, like as far as spearheading this move forward. the majority of this literature is coming out of the VA, and I think it really sets an example for the rest of us and how to begin to approach our research questions. But first of all, studies were not powered to compare or stratify by ethnic race groups. So Monica alluded to this a little bit at the very beginning, that a lot of the studies we found controlled for ethnic race group differences, but they weren't able to compare. So we don't actually know what the factors are that are driving, positive outcomes and negative outcomes. We can make assumptions, but we haven't really tested those things yet very well. And this leads to the second point of needing increased recruitment of these underrepresented groups. So I think a lot of times when we design studies, we want to recruit from our community and we want to be representative of the community that we're recruiting from. So I'm in Central Florida, so I want to, represent a group of people that, or I want to recruit a group of people that represents the population surrounding. But unfortunately, what's happened is over time, this has left large groups of people underrepresented in research. So I think we actually need to take an oversampling approach and start really trying to include people in research that have been excluded thus far. Also, to engage in a systematic approach to analyze these complex factors. So there are multiple factors across these different levels that are interacting, and we need to begin to look at this in a more systematic way. Most of the studies that we identified looked at maybe one or two of these factors at most. But I don't remember any, and Monica maybe you can correct me, that actually looked at these factors across all of the levels, like, one factor from each level to see how are things interacting among our patients. And then finally, more incorporation of these protective resilience factors. So what are the factors that are actually providing protection and buffering the negative influences of chronic pain? Those are some definite areas to move forward into. And then limitations specific to our study. So as with all research, there are limitations to this study. Broader terms could have resulted in other identified studies. But again, we wanted to be really true to the NIH Health Disparities Research Framework to see what we could find specific to that. We also limited our time frame to approximately 20 years, and the location was in the United States and only using PubMed and Web of Science databases. However, those are pretty robust databases, so we felt confident in what we found. We also limited to only chronic musculoskeletal pain conditions. If we had looked at other chronic pain conditions, we could have probably identified other studies as well. And then we limited our sample to adults only. So there is new evidence showing there's, adolescents and younger folks are experiencing chronic musculoskeletal pain, and we don't really know how this influences life trajectory, outcomes later on in life. So that could be another area for future exploration as well. Okay, moving forward. New avenues for research. So one of the, I think, areas that we are just really poised for the first time to begin to explore is the intersectionality across these multiple levels of analysis. So never in our history have we had so much data available to us. And now we have these great artificial intelligence, algorithms, machine learning, natural language processing that we can begin to apply to these really large data sets. So we can start to understand how factors at each one of these level of analyses are interacting. Notably, this is going to be very messy research. And as I sit and think about it, I get overwhelmed a little bit, just thinking about looking at the factors under environmental and how that's affecting sociocultural and how that influences behavior and that's affecting biological and back and forth. However, I think for the first time maybe in our history, we have the ability to actually begin to look at these interactions, and this could be a really fruitful area of research. Another new avenue for research would be applying what we currently know about pain to disparities research. So we have this new emerging lines of research showing that chronic pain is related to the HPA axis and stress and allostatic load and epigenetic changes and cellular communication. But we have yet to, that I know of, and forgive me if I'm wrong here, we have yet to apply that to disparities in chronic musculoskeletal pain. And so this, again, is another new avenue for research that we can begin to move into. And then finally, for this one for me is really important. So kind of taking a new approach to community engagement. And I know a lot of labs are beginning to do this, and I think this is a really a good move. And so traditionally, this is our traditional picture. The academy comprises stakeholders, researchers, agents of change. And the community, well, those are our research participants. However, that has limited us. So what we need to maybe do is transition, next slide, to a new community engaged research approach. And this is being incorporated in a lot of different settings and laboratories right now, where the academy holds its same role, but now the community is also considered stakeholders, research collaborators, and agents of change themselves. So what this allows us to partner with our patients and community-based organizations, so then we can really start to incorporate the lived experiences of people in the communities that we want to learn more about. And it will give us insights where we can develop better questions, inform our hypotheses, build trust. We can design studies and test interventions that will then be easily translated back into the communities that we want to influence, impact positively. So this is one of the new avenues for research. I think we can begin to take a more community engaged approach to research, including people in the early phases of research development, asking what does meaningful change mean to you? What does a good outcome look like for you? What are the factors that you're facing that impede adopting health behaviors? Just to get more information and really improve our research process.
Okay, thank you, Dr. Johnson. So switching gears to the clinical perspective, as you know, I'm a clinician, and back when we were conceptualizing this paper, I work in Jacksonville, Florida, a very underserved sort of population with high socioeconomic deprivation, as well as a large minority group and sort of limited healthcare benefits. And I was sort of struck by the fact that these patients were sort of becoming poor responders to the traditional pain treatments, where at other places I worked at or trained at, it seemed to work much better. And that sort of got me thinking, what are the characteristics of these patients that make them unique in the way they respond? And how does that population compare with other cities? And so now that we've gone through this sort of systematic approach to health disparities, what I've found now are these clinical applications. And as a clinician, I can say that my patient pain evaluation has definitely grown from when I was in medical school several years ago. And they really focused on the biology of the disease only. And now, incorporating the psychological, depression, anxiety, social factors, lower education, poverty, and healthcare influences such as access, quality, and perceptions also come to mind. And just when I look at the electronic medical health record, just looking to see, hey, where's their address? How far are they from our clinic? What's their preferred language? Is it Spanish? Is it English? Sometimes in my conversations with patients, I now engage more about their social circumstances, and are they having any insecurities about housing or transportation or childcare. And a lot of that actually really affects what treatments they are willing to participate in and which treatments they have compliance. And so as a clinician, becoming more aware of these aspects has made me a better clinician, but also has wanted or promoted a future change where there's appropriate allocation of interventions and resources to further offset these health disparities. And that may be at a policy level, institutional leaderships, insurance coverage changes, just to further target and improve the outcomes for these high-risk individuals. And so this is our question slide. I know we saw the chat box, but I'm assuming you'll share your questions with us.
Well, if I could take just a minute to thank both of you. That was really a wonderful, comprehensive, systematic review, kind of spanning research and clinical. I love the way that you gave us that perspective. And I kept thinking, the more we learn about something and we step back and we pull back and we widen the frame, I feel like the more we realize we don't know. So there was a lot when you were going through and saying, well, there's not anything yet here. And I guess we can all choose to see that as a lot of opportunity. But I was wondering if you could each say a little bit about, in really taking the opportunity to review this in this systematic way, if either of you have an area that you think you're most interested in, what you think is the ripest area maybe for further investigation from your own perspective.
Alicia, do you want to take this one first?
Sure. And would you advance to the next slide? I want to give everybody a shout out here. That helped us.
Yes.
So shout out to all of our collaborators. This is everybody who worked on the project. So thank you if you're here today. So for me personally, I and I think this is going to be different for each of us as we each have different research goals, passions, agendas. But for me, I come from a complementary and integrative health approach background. So practicing as a licensed massage therapist for 20 years, I kept being overwhelmed by how homogenous my patient population was. And when I went to the literature and I began to look at the literature, again, I was struck by how homogenous the research literature was. And I thought, wow, this is really telling. So for me right now, my biggest area is to increase representation of multiple ethnic race groups in complementary and integrative health approach research and non-pharmacological pain management research. We are, again, I'm biased here, but when I look at my niche of research and I'm just struck by, it's like, wow, this is like the Whole Foods community. What about the rest of the world? And so for me, that's where my passion is right now, is to really improve our recruitment of different populations of different communities into these types of interventions. And I was talking with somebody the other day about this, and it's, this I think is where that community engaged research can really start to come in. Like, what are people willing to do? What do people want to do? What brings value to their lives? How will this actually improve their health? Is it something that they can adopt into their lifestyle right now? And again, just a shout out to the VA and the whole health initiative and everything you guys are doing with that. I was reading a paper the other day that was talking about it was predominantly female veterans, and they were looking for different ways to manage pain, and they were polling on like, what would you be willing to do? And I was struck by the fact that, a large group of people that are underrepresented in massage therapy research really would like to get massage therapy. And it's like, wow, these things just need to be investigated. So I think for me, that's definitely one area that's right. And then again, just starting to think about how these multiple levels interact with each other. And so it's not just lack of transportation or built environment, or values or beliefs or education. It's how all of these things are influencing each other and interacting.
Yeah, thank you. My research, I basically became inspired by my population. So I actually had to pioneer research on my campus for my pain clinic. We had never done research before, and I was lucky to have great collaborators and funding opportunities that I got. And my first goal was really just observing or further characterizing the population that I had, because there had been such little literature on it, and I felt like I had a very underrepresented population. And I was able to really successfully recruit almost half minority patients and half non-minority patients. And I developed a survey that sort of was, the goal was it would be easily administered in a busy pain clinic, and looking at factors that we don't necessarily think of, but also that the NIH has stressed, such as the social determinants of health, but making it very specific to chronic musculoskeletal pain, which is the majority of the patients I see. And so that was my first target. And after that, we developed a biorepository of different serum, saliva samples, looking at different opioid risk, because there was a high substance abuse population that I was working with, looking at different phenotypes and opioid risk factors. And also the work that I'm looking at right now, which I'll probably be publishing in the next few months, is looking at different epigenomic changes specific to this population and different gene targets, which interestingly are the targets that I found share targets or shared with other comorbidities that I find very prevalent in my population, such as congestive heart failure, diabetes, obesity, hypertension, stroke, and the literature shows similar targets for that, especially in minority or lower socioeconomic status patients.
Thank you. So I'm going to invite anyone else who has any questions to either put them in the chat or just go ahead and speak your question. I think we can probably, we can take turns.
I'd love to ask a question. Can you hear me?
Yes.
Into the camera. I'm Una Macrease. I'm at the Dallas VA in Texas. That was an incredible presentation. Thank you both. Very enjoyable. I'm a rheumatologist, and I work exclusively on aging research, so aging and musculoskeletal pain. So this really spoke to me. I just wanted to put something out there, and you really looked into the literature here. Did you find anything regarding ageism and musculoskeletal pain? And if not, I'm wondering if this group might want to collaborate on a qualitative project or some project that kind of investigates the patient perspective, maybe, regarding ageism and kind of a integrated interdisciplinary approach to musculoskeletal pain.
Yeah, that's a great question. I did actually on my search find a very few number. I think it was maybe 2 articles on the older adult aging perspectives of pain. And the results from my memory are that it was generational, with stoicism definitely being a factor, but that in general, as patients aged, particularly as they got closer to like 80 or above, they were expecting to have severe pain, and that was sort of something that they thought was normal, that not necessarily something that they thought they could actually go and get treatment for and get fixed. So that was very interesting. And I do think that is maybe an educational intervention or just further classifying those perspectives would really help. as well as just noticing that different birth cohorts, the younger generations compared to the older generations that may have more stoicism or other cultural biases, how that interplays as well.
I will say that I wonder, what we can learn as clinicians and healthcare providers. Sometimes we say things and we don't know how it's perceived on the patients. And I think what patients are teaching me is to guard against good enough. And that is that my interpretation is that their function or their pain is good enough. And I think that we can't assume. We must be asking our patients. And I would just love to kind of dig into this a little more. How is ageism perceived from the patient perspective? So I'll raise my hand to be a collaborator for anyone who might be interested.
Thought I saw Bob turn on his camera there, so I was wondering if he had a question. No? Oh, he has no sound. Got it. Give others a chance to ask anything. I'll jump in. So I had a question about passive coping. So Elisa, you mentioned passive coping and some differences there in outcomes with passive coping. And I was wondering if you could just elaborate a little bit on that, because that is something that comes up quite a bit.
So I think, yeah, when we think about our different types of coping, we've traditionally split it into active and passive, right? So active coping are these really engaged ways of coping with pain. And then we have our passive coping strategies, which I think have been perceived as, negative. So some of the things that are evident here are prayer, coping, problem-focused, emotion-focused types of coping, and that's been labeled passive coping strategies. But I think we need to really guard against this assumption that because it's a passive coping strategy, it's a negative coping strategy, because it's maybe not negative in all groups of people, right? And so for some people, hoping, prayer, focusing on, the emotions that they're feeling, those actually become adaptive instead of maladaptive. Of course, they can function as maladaptive processes, but I think what we're seeing, just a little bit of literature that we found, is that it's not maladaptive for everyone. So for the African American women that were in the one study that we found on knee pain, they reported higher use of emotion-focused and problem-focused coping strategies, but they actually had less pain. So pain was negatively correlated with use of those strategies in the African American women. And the non-Hispanic white women, it was the opposite. So use of problem-focused and emotion coping strategies was associated with greater pain. So again, I think it's just a lot of these factors don't always work the same. And so we have to be really careful in our assumptions when we go into our studies and how we measure and the questions that we're asking. And I think this could be a really good, you asked about areas right for research. I think this is one of them. So how people view their pain, how they cope with their pain, and just those processes, how they work out across different ethnic race groups, I think is a critical part of learning more about how we can mitigate pain disparities.
Yeah. And I also think that the passive coping versus active coping isn't an independent factor like we had discussed. It also then spills into how they make their medical decision making, right? And so if they have a more passive approach or they don't feel like they're in control of their health outcome, then that's a very different outcome than if they are using active coping strategies and actively seeking care and actively engaging their healthcare team. So like all of these factors, they sort of interplay, and that also makes it very difficult to see them in isolation.
I see in the chat, Dr. Kern says he put a question in the Q&A, but I went to the Q&A and I can't see it, so help me.
I didn't see it either. Actually, wait, let me make sure. Hope I didn't miss it. I'm looking here.
Hold on, I got you.
Oh,
So Bob says, it seems intuitive to call for, quote, increased recruitment of underrepresented groups. However, given differences in willingness of ethnic and racial groups to participate in research, how can researchers try to mitigate these differential recruitment rates and potential bias in findings?
I agree 100% with that. I think this is where that community engaged research can really begin. And so when we think about, developing focus groups and going into community-based organizations where we engage the community, we ask people, come tell us what is important to you. What are you willing to do? What do you want to know more about? What can be helpful? Monica, do you have anything?
Yeah, I think that's great. I actually, when I was going into pioneering research in my clinic, because it's a very minority, lower socioeconomic status, everyone kind of warned me, oh, but they're going to be fearful of research, right? And I was like, okay, well, let's give it a try and see what happens. And what I found was that they were actually so willing to participate. One, because they had already built that relationship with me as a doctor for many years. And so they felt comfortable with it, right? And so it wasn't so scary because they knew what they were getting themselves into. They kind of built that trust and that fear was gone. So without having that, I think it would have been really hard to recruit. And I think that community engagement, if they are not your patients or they're not someone where you have the ability to build that relationship before you recruit, it is difficult. So the community engagement, partnering with a community leader who has built that would be really helpful. And I think that already we know health disparities involves patients not even being able to get to a healthcare organization, right? So going to where they're at really makes a difference.
Yeah, and I'll piggyback on that too. I was thinking about having a community advocate. So somebody that you can go with that is a community leader and going into places where people already are, churches, community organizations, civic centers, to meet people, at easily accessible where they are and to show your willingness to engage and listen.
I appreciate that. I think maybe that is us as researchers thinking about being more active rather than passive. To borrow that, so like actually having to take that extra effort to go out and try to meet with the community and understand their concerns or interests, as opposed to casting a much more narrow net and then whoever comes. And I appreciate you're talking about stakeholder meetings. The VA has really promoted veteran groups and encourages people to view veteran stakeholders and try to involve them. So I think we're also starting down learning the importance of that. So I see that we're at the top of the hour. I want to thank you again for this wonderful presentation and discussion, and I appreciate you being with us. And I appreciate everyone who's attended. I will see you all next month, and we will soon be sending the RFA I mentioned earlier to the email list. So for all of those who wanted that, should be forthcoming. Thank you for joining us today, and I will talk to you next month. Thank you.
Thank you, everyone.
Thank you very much.
Thank you, Dr. Powell, Dr. Johnson. Thank you.